day-to-day life, or other. And so it could be a science that could have been noticed, but it wasn't. At age 18, only age 18, he had a physical examination, a good physical examination, revealed a bilateral extensor palmar response, a distal muscular atrophy of the antero-external aspect of the legs, a distal hypoesthesia at the lower extremity up to the ankles, and he benefits from an electromyography which shows a sensorimotor axonal polyneuropathy affecting all extremities, which is not very common at this age. The MRI at this stage was considered normal. It's very important for us to know that MRI are often considered normal, even if a few years after, when you have the diagnosis, you see the MRI and you find something. But it's very important to know that when it's written a normal MRI, it's not always a normal MRI. It's really because his MRI was not normal when seen after all. At age 21, so you see, it takes a lot of time. This story is very paradigmatic of many, many cases. That's why I like it. Plasma cholesterol was found to be elevated. Okay, and the sequencing of the gene and CTX diagnosis was made. He benefited from treatment of chenodesoxycholic acid, 250 milligram 3 times a day, with no other treatment, especially no psychotropic treatment at all. What is interesting, I made it short, but he had also a sister. Sister is in red, is in pink, and he is in blue, because I'm very conventional. And so here you see behavioral scales, and the less the scale, the rate is, the better is the behavior. And you see after 18 months, 1 year and a half, that all behavioral scales went down only with acid chenodesoxycholic and with no psychotropic medication. It changed many things for this patient and her sister, 2 years older, because they had no school, no job, couldn't live alone, and now it makes 5 years. They are living in Brittany, west of France, alone, or both. They have a job, not a great job, but they have a job, and it changed everything for their life. And the boy, not a girl, but the boy has a girlfriend, so it changed also the life. So it's very, very important. More important, we made, you cannot see here, we made a lot of cognitive examination, and after 18 months, many of them did improve. With the improvement in cognitive performance was especially important in, time is going, I can't see my computer now, was in proceeding speed, which is quite important for everything when you read and when you think about things. It's very important. Improved also in attention and impulsivity. Improve also, and most important, in there we go. In information seeking, which is very which is very important because it's kind of naturalistic thing. It's very important to improve in cognition, but in real life, what is important is to be very quick in finding information in documents. And so we found that he improved in cognition, but it also improved in the final aspects of the thing. And it was not a great improvement, let's see. But we see that in only 18 months, all both patients improved a little bit in cognition. So we could imagine that if treatment were started earlier, and it could have been earlier, it could have changed a lot of things in this patient. That's why I think it's so important to really have in mind all the time that in a patient, and the first things we learned when I was a young psychiatrist is first thing in psychiatry, you just have to eliminate and search for organic disease and not forget that. And also it's important when you are not psychiatrist, when somebody, some of your colleagues or psychiatrist colleagues come to you and say, I think this patient is not totally classical for my opinions, you should really listen to him because usually they know that, I can say they feel that, and you really have to search. It's not so easy because even if I work for a very long time in a very large hospital in Paris with a lot of neurologists everywhere, usually when they came and to examine our patients, it was difficult because behavior was, they were aggressive or things like that, so they were difficult to examine. Sometimes it was difficult to just to take blood sample from them. So they say, okay, I can't do today, and next appointment will be in 6 months. In 6 months later, it's the same thing, they cannot, and it can go like that for years. So really you have to form and to help to practice for neurologists, endocrinologists, and even nurse to examine and to take blood sample of patients with psychiatric disorder to help and to improve the rate of diagnosis made in this population. I'm working with a group of psychiatrists interested in this field. We are not many, but we are in different countries, and we start to think about psychiatric atypical signs, which may be found in psychosis, but also in other disorders, which may trigger us to search for inborn for neurometabolic disorder. And some of them must be known. Some of them are known for many years, but some of them must be known. So that's why I'm presenting them. It's very known that in neurometabolic disorder, for example, you have visual hallucination, but visual hallucinations are not so rare, so it cannot be a sign like that. But visual hallucination, more important than other hallucinations, especially auditory hallucination, which are not so rare also, is really an important atypical sign. For example, if you have schizophrenia, you may have a lot of hallucination, olfactive hallucination, gustative hallucination, synesthetic hallucination, feeling on your body, and auditory and visual hallucination. But no, it's very atypical to have visual hallucination. The first one, the main symptom, the main kind of hallucination is not visual hallucination. If you have a visual hallucination alone, which is very, very rare, if you're a child, it's almost normal. 4 or 5% of all children have visual hallucination. One is very known, is the imaginary companion they have, but it's not so important. You just have to check that and to see them. But it's very important to distinguish visual hallucination from other type of hallucination. Second one is confusion, which is more classical. I go there. Third one is catatonia. Catatonia is important. I said earlier, because in catatonia you have 20% of organic disorder, catatonia from a psychiatric point of view, and so it's very important to have an extensive search. Next is progressive cognitive decline. Usually in psychiatry there is no progressive cognitive decline except for the first years after the onset, and so it's very important when patient is able to do something in writing or in learning and is not able to do it after a few years, to ask if there is an organic disorder, especially a genetic organic disorder, an inherited. What is also very important is treatment resistance. In many cases of neurometabolic disorder we see that treatment resistance is very, very important, especially psychotropic treatment resistance. You all know about Wilson disease, which is quite common in psychiatry, quite common more or less, Wilson disease have 50% of Wilson disease have psychiatric disorder, and 20% of them have presenting psychiatric signs. And we know that in Wilson disease, when you give antipsychotic, patient is resistant to treatment, but worse, it worsens the symptoms of the psychiatric symptoms you have. So it's very important when you have no response in antipsychotic, for example, or even other psychotropic treatment, to think about neurometabolic disorder. It's really a large science. And the first idea in psychiatry is when it doesn't work in one titration, you up the titration, and in this case, you also worsen the symptoms. So it's really important to know and to think about that. Because we know that antipsychotic are treatment, for example, who are working very well in 70% of all patients. So we know it's working very well. So if it's not working, we should think about organic disorder. The fluctuation of symptoms of almost all psychiatric symptoms, it's not also very classical. Usually when you are depressed for a long time, it doesn't change. You may not be depressed from one night because some of your friends drag you out to go to a party or something, but when you go back, you are still depressed. You don't have a very, very large fluctuation unless you are bipolar for depression, for example. Acute onset is also a sign for organic disease and also for neurometabolic disorder, when I think about urea cycle disorder, for example. And so it's also important. It's not usually going like that. We know that psychiatric disorder may be triggered by toxic, for example, but it also may be started by because they have organic disorder. Early onset, I said previously that in early onset, for example, schizophrenia, you have a large prevalence of disease, organic disease, so it's important. And intellectual disability, which is not associated with many of psychiatric disease, except autistic spectrum disorder, because half of the patients with autistic spectrum disorder have also intellectual disability, but it is not the case in depression, of course, but also in schizophrenia. And it's contrary the case in many of neurometabolic disorder and in CTX, for example. Unusual side effect is also an important science because, as you know, for example, psychotropic treatment have a lot of neurological side effects, especially antipsychotic. So it can be maybe sometimes confusioning if you have a movement disorder, even an ataxia or dystonia. It could be thought to be related to the antipsychotic treatment and not being recognized as the first neurological signs of a neurometabolic disorder, for example. So it's also something you should think of. So I made a little sheet, it's a paper sheet, I finished it. Very easy that we use in my center, and in the west of France we start to use it. It's just something that I wish all, but it's just a part of psychiatrists should have on their desk when they see a patient, especially a patient with schizophrenia, and they just have to quote, to mark if the signs, all signs I said earlier, are present or not, or if they are, and if they are present, if they are the main symptoms or very important symptoms. We don't have cutoff for this sheet because it is kind of algorithm because we don't know yet, but we are working on it, and a study is in progress. So you are free to use it or to distribute to everybody if you want. And I thank you for your attention, and I think I take my time.
But I think we should have at least 10 minutes general discussion on this the key questions, maybe even though the discussion may go on later after the other sessions. And so I please ask the other two speakers to come up, and maybe the three of you can answer some questions from the audience. Just maybe 10 minutes before the coffee break. Is the translation working fine? Yeah, everybody's okay? Translation. So, any questions? Please don't be shy. I'm sure you must have many, many questions. Of course, Estefania, go ahead. Thank you.
Hola, bueno, yo voy a hablar en español para que me entiendan también los familiares mejor. Bueno, nosotros estamos muy agradecidos, por supuesto, a ustedes, a todos los que habéis venido para tratar esta enfermedad. Y bueno, nosotros estamos muy contentos de tener a alguien especializado en los problemas psiquiátricos, en el Psychiatric Problems about Disease, que creemos que son muy comunes y a veces más deshabilitantes que la propia enfermedad y sus síntomas neurológicos y físicos.
Okay, Stephanie, hold on just 1 second. Okay, so far she said thank you so much for having come here in the name of the families and patients to everybody, and that she agrees with the importance of psychiatric symptoms, which are very disabling, sometimes much more than motor and other symptoms. And I don't know if now the translation is going to go on now that she has a microphone.
Okay, yes, do you hear me? Okay, it's okay? Okay. See, it's working. 1, 2, 3. 1, 2, 3.
Otherwise, I can translate.
Okay. Just to ask Oliver Bonot if he has any experience, alguna experiencia, si tiene experiencia en nuestro caso personal hemos conseguido sacar de una fuerte depresión a nuestros familiares que son pacientes de CTX con la terapia electroconvulsiva porque tenían gran resistencia al tratamiento psiquiátrico que se le estaba administrando, y la única manera fue a través de algo que está ya como fuera de uso, que fue la terapia electroconvulsiva. ¿Tiene usted experiencia en este tipo de terapia? ¿O cuáles son los mecanismos, las medicinas que se suelen utilizar en las manifestaciones psiquiátricas, o son las generales según la manifestación psiquiátrica que tenga? ¿Son las generales que se siguen, o alguna especial para estos pacientes, o la terapia electroconvulsiva si tiene algún tipo de experiencia? Gracias.
Should I translate that?
Well, I think I will say what I understand and you will complete. I think she asked me if I have experience about electroconvulsive therapy in this kind of patient, because in CTX in particular,
especially for severe depression.
For severe depression.
Or whether treatment should be the regular treatment for depression, or how would you treat these patients like?
Because of the small amount of patients, there is of course no studies of this kind of therapy in the patient with CTX and even in neurometabolic disease, but we have the experience of electroconvulsive therapy. Electroconvulsive therapy is very changing at the moment, because techniques are very changing. We have a classical electroconvulsive therapy, but we have also superficial and cortical stimulation, TMS, or even now there are other kind of stimulation which are less, let's say, less aggressive, more superficial, and maybe more easy to use. We use some of these different kind of therapy, electroconvulsive therapy and TMS, not in depression. Not in depression, we don't use it because we think that it's not. I'm a child psychiatrist, so I did it in child and adolescent. So we were a little bit scary about using it. So we are using it very. We think really much about before using, but in a patient with psychotic symptoms, and it worked very good because they have treatment resistance, and in general, electroconvulsive therapy is a very good treatment for psychosis. We don't use it because It's sometimes complicated, and sometimes patients don't want to have it, but it's a very good treatment. And there is very few side effects, sometimes very transient loss of memory, but very transient, but no metabolic effect, side effect. So it really was working. And you give me a very good idea, because we have some cases like that, and we could combine them in a case series and publish them, because it could be interesting. But we didn't use, in my experience, for depression, because we don't use this kind of therapy, maybe RTMS more, for depression, only for melancholic depression in bipolar disorder.
Thank you so much. Dr. Federico?
Yes, may I have some comment about this problem of psychiatric disorders in general, in neurodegeneration. And what we learn by neurodegenerative disorders, like for instance Parkinson, Huntington chorea, and other well-known disorders, even to Alzheimer's disease, is that when the brain still is functioning, there are psychiatric symptoms before the neurological symptoms appear. So in Parkinson, for instance, we have depression starting 10 years before symptoms appear, then appear neurological disorders. And similar situation is in general in neurometabolic disease, and we have very strong examples of neurometabolic disease. For instance, metachromatic leukodystrophy, late onset, is the best example of a psychiatric disorder that start with schizophrenia-like symptom and then appear neurological disorders afterwards, after several years. The same is cerebrotendinous xanthomatosis. So what we can think as a brainstorming in this group, I think that it is very useful to understand what is the basic problem that lead to neuropsychiatric disorders and then to neurological disorders. In my opinion, and was the reason that I reported the article, the basic article on neuropharmacology of several metabolites that influence the neurotransmitter, several neurotransmitter, GABA and other. So there is some membrane alteration related to substitution of cholesterol with cholesterol into the membrane of the brain structures, neurons, leading to neurotransmitter abnormalities with some areas that are much more influenced than others. So we will have calculation abnormalities or even psychiatric minor symptoms, and then when the situation is very severe, we will have neurological signs. So I think that we need, now we have some technologies that are able to investigate the brain, for instance functional MRI, PET and other data. So we have to use those models as a model for understanding the role of an enzyme deficiency and metabolic abnormality to investigate the possibility of brain changes and also the treatments, because we have no knowledge what happened with chenodeoxycholic acid treatment and neurotransmitter. For instance, I learned in the experience of GM2 gangliosidosis and Niemann-Pick, we have done several in vitro investigations that, for instance, chlorimipramine, if you feed fibroblasts with chlorimipramine, you have a model of Niemann-Pick in vitro in normal fibroblasts. So there is an influence in the transport of cholesterol into the cells, feeding fibroblasts by imipramine. That is the most frequently used antidepressant. And this was the reason that we published this, that is not useful to use imipramine in GM2 gangliosidosis because there are some side effects. So you mentioned that there are some side effects of treatment, and we don't know what is the interaction of several drugs with the basic abnormalities in many neurometabolic disorders. And I think we had some line of research to do in order to investigate the cause of a problem related to treatment.
Thank you. Thank you. These are really interesting thoughts, I think, related to this, what is being discussed, and psychiatric manifestations and how we can treat them, and why they would have some specific side effects. I have a quick question for Dr. Verrips. Would you recommend routine screening for CTX in neonatal prolonged jaundice? Just very specifically, yes or no, and why?
Yes, I think, yeah. And, well, neonatal screening is feasible, but not yet validated, and we have to identify, I think we can identify more young patients, and that is good to look at.
Okay, so the answer is yes, and the biochemical neonatal screening is not quite yet there, although we'll hear something about that later by Dr. Gocho and more discussions. So why not just genetically check them every prolonged neonatal jaundice? Do you do that regularly in your country?
In the Netherlands, it's not done yet, but it's a good idea, and let's start with it.
Okay, that's one action point already.
Yeah.
Have we identified one action point? Okay, any additional questions, or we can keep on this later on, even though we are going to change topics a little bit. We can always come back. I mean, I'm sure we're going to be coming back to these topics, so maybe...
May I ask a question to Professor Federico? And
of course.
A part of my patients speak very fast in the early years of the disease. We call it tachylemia, and there's a very fast speech rate, very increased. Do you recognize that?
Yes, it is present in the early stage.
Yeah, yeah. Have you any theories about the...
I am not familiar with this type of behavioral changes, but it is very interesting.
You guys are worrying me because I speak quite fast.
Did you in your patient?
Yes. No, I didn't see it, and I didn't notice that. But it's a very good question, because we know that patients with impulsivity speak very fast. So it could be also a sign of this impulsivity, because they are really, really marked by impulsivity when at young stages, like the patient I present. But the few of them I saw were like that, pediatric patient. It could be an idea, but that's all.
May I ask a question to Dr. Verrips? Thank you for your presentation. A practical question, which is the cutoff age until you give a lower dose of echinidioxycholic acid, 5 milligrams per kilogram?
Yes, that's a very good question. We don't know yet, because we now have one patient with a good response biochemically and clinically at low dose of therapy. And the patient described by Clayton has been treated with cholic acid till he was 11 years of age, and he showed no of it neurological symptoms and signs. And then the treatment after diagnosis was changed, I believe, in phenodeoxycholic acid. But I don't know the cutoff point, and well, you can speculate on this because hepatitis of infancy, how long does it is going on? And in the Clayton patient, it was going on for several years. And well, I don't know if a normal dose of phenodeoxycholic acid